So I'd like to say welcome to you all tonight. Welcome to another WellFemme webinar. Tonight's topic for discussion is dementia risks and brain glitches at menopause. And our special guest presenter is the lovely Dr. Marita Long, who also happens to be one of our fabulous WellFemme menopause doctors. Welcome, Marita.
Thanks very much, and thanks for inviting me to have this talk, because it's something that I'm incredibly passionate about. And I think by the number of people who registered, I think lots of women are thinking about, the worry of some of the cognitive changes and how that might relate or add risk potentially to dementia. So that's great.
Absolutely. It's a hot topic. You and I both know how many of our patients are really worried about the fact that they're getting brain fog and that their memories are sliding a little bit. So we'll be able to talk all about that tonight. Before we get started, I'd like to remind everyone that this presentation tonight is for informational purposes only. So you shouldn't interpret this in the context of your own individual situation without the advice of a medical doctor. So I do recommend that if you're interested in following up about any of these things in the medical context of yourself, you should speak to your doctor or even one of our WellFemme menopause doctors if you like. Okay, so as mentioned earlier, you can post any questions during the presentation in the chat box, and also we're going to stop at the end for some Q&A. This will be recorded, so you'll be able to watch it back later, and we'll be sending out some resources to you all after this as well. So without further ado, I'm just going to introduce Marita properly. Marita is a Victorian-based GP working 3 days a week in clinical practice and 1 day doing medical education currently. After completing her certificate in sexual and reproductive health, Marita worked for Family Planning Tasmania, and she's positioned herself well, consequently, to work with women across the various ages and stages of their lives. She's developed a strong interest in menopause and recently became a board member of the Australasian Menopause Society, who we menopause doctors love very, very much as a fantastic source of evidence-based information. Marita is also a current committee member for the Australian Society of Psychosocial Obstetrics and Gynecology. And in her medical education role, Marita developed and delivered many educational face-to-face and online workshops, and is passionate also about upskilling GPs to deliver the best evidence-based care for patients. And Marita also presents on radio, podcasts and webinars, and she works with Dementia Training Australia, which is one of the reasons why she's become so expert in this topic. And Marita, take it away. Why don't you talk us through everything we need to know about dementia risks and brain glitches at menopause?
Great. Thanks, Kelly, for that. So before we begin, also it's important that we acknowledge the traditional owners of the lands in which we are meeting today, which is all around Australia and New Zealand, and pay our respects to past, present and emerging leaders. So today, what we're hoping you'll come away with by the end of the webinar is that you'll be able to understand some of the differences between the cognitive changes of dementia and those changes that we experience at menopause. We'll discuss the effects of estrogen on the brain. We're going to talk through the modifiable risk factors for dementia, the things that we can be doing now to prevent dementia or delay the onset. And we're also going to really explore how to optimize our brain health now and for the future, which is really important. So I guess we'll start just with a quick wrap of what actually is menopause. And menopause it's a natural part of our reproductive life. It's sort of the end of that reproductive phase and when we enter into a new phase. And it's marked by the 12-month mark after our last normal period. It's important to keep in mind that transitional or perimenopausal time can be very, very varied for people. No two women with menopause experience the same thing. And of course, that's because our lives are all different. So our circumstance, what other illnesses we might have, our understandings, it's all impacts on our experience for menopause. In some cultures, it's really celebrated. So a lot of the Asian cultures, when women become postmenopausal, they're thought to be very wise and people will go and seek advice from them. In Australia and a lot of the sort of developed countries, outside of Asia, sometimes it's got much more of a stigma attached to it. And I was reading an article that was in the Sydney Morning Herald of a scientist, I can't think of her name now, and she was talking about the situation in Britain and how it's estimated 1 million women in the menopausal period leave their jobs because the symptoms can become so burdensome. So menopause is significant. So it's really important, I guess, to have an understanding of the main things that happen in menopause for our body. And it's a very complex process, but I guess the most simple thing that we tend to think about is the loss of estrogen. And that loss can manifest in different ways for different women, and we'll talk about that in a minute. And it's important to recognize, I guess, that our body does go through an adjustment phase, and that happens at every stage during our life. So if we think about before we enter puberty, where we don't have a lot of estrogen, and then we go into puberty and we start liberating estrogen, there's a huge transitional phase. And again, as we go through pregnancy, huge transitional phase, and then it's no different in menopause when things start to change again.
I've heard of menopause being referred to as reverse puberty, Marita, as well, and that
Yeah,
you get that similar kind of intense rewiring of the brain going
yeah,
on at menopause, similarly to what you do at puberty.
yeah. And the good news is we all get through puberty, so we're all going to get through menopause. So
Yes.
So when we think about the symptoms, and there are very many symptoms that are incredibly varied, as I said before, no two women experience menopause in the same way. But the things that we really attribute to the change in estrogen, I guess, are the vasomotor symptoms. So that's the hot flushes and the night sweats, which can be incredibly burdensome. Some women really sail through menopause, but it's estimated probably half have bothersome symptoms. The second group is what we refer to as the urogenital. So our reproductive organs and our urinary tract get affected. And that manifests for most women by having very dry vaginas, painful intercourse, which we term dyspareunia. And women often notice that they're needing to go to the toilet more often.
Mm.
Um, it's really important, I think, to raise the urinary issues here, because what we find is a lot of women get very embarrassed about their urinary symptoms if they've got incontinence or frequency. And not always are we as doctors mindful that we should be asking women. And we should, it is something that
Mm, mm.
is something we should be doing. But please, if you're having symptoms like that, please try and find a GP who you do feel comfortable to talk about them, because there's things that we can do for that.
Or
And then,
even see a pelvic floor or a continence physiotherapist as a great start
yeah,
point as well.
yeah, and I think a lot of women feel so embarrassed and ashamed, yet so many women have these symptoms, don't they, Kelly?
Absolutely.
Yeah. And sometimes these get worse in menopause. And then we get the sleep disturbance, which for some women will be around having the hot flushes and night sweats. And I don't know about you, Kelly, but I have some patients who have drenching night sweats,
Mhm,
which are
mhm.
associated with
Yep.
menopause, where they've got to get up, get changed, change their sheets, sleep on towels. It can be really debilitating. And so
Mm,
if that's happening, your sleep is going to be pretty awful. We do notice a change in mood, again, with those reproductive changes, puberty, pregnancy. We often see change in mood. And this is really described as low mood, not a really a severe depression. If there's a severe depression, that's often means there's a lot of other things going on. It's not usually just related to those change in the hormones. So that's
mm,
another important thing to keep in mind. So the other thing that we're very aware of is that probably half the women during that transitional phase or in the postmenopausal phase report this brain fog, where they have real difficulty concentrating or remembering things. And so for me, the things that I notice and the things that patients tell me is that, when you go to the pantry and you're like, "Oh god, what did I come here to
Or
get?"
why are the car keys in here?
Yeah, and it's that thing of, "Oh god, what the hell is going
Mm,
on?"
mhm,
And then you sort of walk out, and then all of a sudden you go, "Oh, that's right. I was gonna get the peanut butter," or whatever it was you were gonna get. It's also distractibility. So, last night I got home really late from work. My husband wasn't feeling great. We had a meeting actually too, didn't we, last night?
Mhm.
And then I decided to get a whole lot of jobs done, and so I put the chicken on to cook for the dogs because I have a very fussy dog, and then I sat down and started knitting, and before I knew it, I could smell that the chicken was burning. So we get distracted, easily distracted. This is part of what happens. Missing appointments. I can't tell you how many patients who we see for menopause who forget they had an appointment, or, they get
Mhm.
a half an hour late. It's like, "Oh
But
my
don't
god."
worry, girls, if you don't show up for your appointments, we'll phone you, okay?
Yeah, yeah. Well, and we get it. We
Yep.
understand it. And, concentration can become quite difficult. So they're things that are very, commonly reported at this stage. And the good news is these on their own aren't an early marker or a risk factor for dementia. This is part of what happens in menopause. And I
Mm,
think once people understand that, just taking that pressure off to think, okay, most women or more than half of the women going through this are going to experience that, you tend to relax because
mm,
there's nothing worse than if you're thinking, oh my God, I forgot this, I burnt that, I put my wallet down and couldn't find it, don't know where my
mm,
car keys are. If you start thinking that, oh my God, do I have dementia? Then all of a sudden you get caught in this higher level of anxiety and worry and stress. And of course, what does that impact on?
mhm,
Our ability to concentrate, our ability to remember things. So you sort of get into this vicious cycle then of thinking there's something wrong and almost manifesting that there
mhm,
is something
mhm.
wrong. So you
There's
can
lots
always
of
afford.
comments in the chat box that are validating exactly what you're saying right now.
Yeah, and I love that, Kirsty says, "I'm constantly having to set alarms for myself to remember things," and that's
Mm,
perfect, and that shows by doing that, it shows that you have the cognitive capacity to do that. So
right,
someone
and
who's
making those systems, right, to help support
yeah,
yourself is part of getting through that and working it out.
yeah, so that's
Mm.
fantastic. I'm lost without my list. I've burnt the boiled eggs, yep. I get it. I know it's happening there. And moving on here. So why is it that we have these things happening at menopause? And of course, the exact cause is unknown. Look, part of the issue around all of this is that women have been left out of the research agenda for a long time. So we've been thought to not be able to enter into a lot of research trials or studies because of, it could be risk of trialing a medication if we didn't know we were pregnant, those kind of things. So a lot of
Mm,
uh, a lot of the research around lots of different things that happen to the human body are based on 70-kilogram white, middle-aged men. So we're just starting to learn all these things about what's going on with women. We're starting to get a voice in a space, which is really fantastic. So
mm,
exact cause is unknown, multifactorial, and I'll keep coming back to this. We talk about women who are in their menopausal phase and the transition phase is living in what's called the sandwich generation. I'll be really interested to hear if a lot of you can identify with this. So this is where you might still have dependent children at home. Sometimes they can be adults, or sometimes they'll be younger. You might be looking after grandchildren. You might have a partner who's unwell. You might have elderly parents that you're caring for, and you might be trying to work full time as well. So there are lots of other factors that can impact.
mm,
Depression can really impact on our ability to think clearly and concentrate as well. So there's often things going on. But in terms of some of the things that we do think is happening to the brain, and the picture that Kelly's put on here is just perfect because there's a neuroscientist, is it Lisa Mosconi?
yes, she's
Yeah.
brilliant. Mm,
And she talks about a part of the brain that in all these reproductive phases gets pruned back. So we
mm,
kind of shrinks a bit, we prune it back, we offload stuff we don't need anymore. So think of, pruning one of these trees back. And what
mm.
happens after you give something a good prune? It
It
grows,
regrows.
blossoms, and it gets stronger. So the thought is that at each of these different phases that, there's a little bit of pruning back, and then it comes all back together for us.
Yeah.
And
Is
we've
there
begun to
some evidence there? I thought I had seen somewhere that they've actually shown with brain scans that there's physical shrinkage of women's
yeah.
brains around menopause. That they actually see that.
Yeah,
Mm,
and then but it does recover,
mm,
and the Jen Gunter, do you follow Jen Gunter on Instagram at all?
mm. Oh, not I don't follow her, but I've read her books and they're brilliant.
Yeah, she's
Yeah.
terrific. So she, gave a great, I think it's a simile, you see. So she talked about your phone, your iPhone. Well, I'm an iPhone girl. I'm not a Samsung, or a Google. I'm an iPhone girl through and through. And you know when your iPhone starts to lose battery all the time and, things
Mm,
don't work so well on it, and then you realize, "Oh, okay, it's time for an update," and you'll update the software and then everything's new also after it's updated.
mm,
It's like, "Oh, it
mm,
doesn't look the same, and I can't find things as easily." But then once you've adapted to that, you
mm,
love it. It's like, "Oh, this is so much better." And so she likens this transition point to like an update of your operating system, and I really like that because it does give that sense that, yeah, it's rough, it's tough, it's changing, but it's gonna be okay, and in fact, it's probably gonna be better. And,
mm,
for lots of women, menopause is a really liberating time, for those who are lucky enough to have had their adult children move out
mm.
and, who, are thinking about winding back potentially at work, and you don't have to worry about getting pregnant anymore. And there can be lots of real
Mm,
liberating facts. It's not all bad.
absolutely.
Yeah.
Rhonda's asked a question that's relevant at this
Mhm.
point. She says, "Is the physical change in the brain all in the same area of the brain, or is it again just that everyone wears menopause differently?" Sort of, so
No, I
different
think
parts of the brain.
there are specific areas of the brain where this happens,
Mm,
but keeping in mind that other people will have other things potentially going on. So for someone
mm,
who perhaps has had very high blood pressure or diabetes, there might be other changes going on. But in terms of the
mm,
menopausal change, generally it's considered
mm,
the
mm,
same area. And
right.
I just wanted to comment on Barbara, the UTAS for the MOOC, which is
I
one of
saw
our
that,
resources.
yes.
Fabulous. Terrific that you've done that and that you think that they're so good. And Ruby, who has said, "Are crosswords and reading good for brains?" And this is a really interesting one because we'll talk about that later. So Ruby, if I don't answer that, just
Mhm.
pop that back
I
up
will
when we come.
remind you. It's all good.
Yeah, remind me about that.
I'm
Yeah,
your system tonight.
excellent.
Mhm,
So now we sort of come to what is the role of estrogen, particularly on the brain. And again, we are still learning a lot of these things. So I'm not a neuroscientist and I'm not a neurologist. I'm a GP who's got a real interest in this area. So so estrogen does interact with our brain and our neurotransmission. We know that estrogen is protective because we know that after menopause, we do become at higher risk of different diseases. So, for example, our bone health can suffer, our heart, we can be higher risk of heart disease. So, we know that there is a protective factor there. And in terms of the brain, there seems to be a role in the function and survival of our neurons, so our brain cells. The brain volume can be impacted, and we do then develop a slightly different risk to men for things like Parkinson's disease and Alzheimer's dementia, for example, which we'll talk about later. And of course, there is this effect on sleep with the loss of estrogen, and that's partly because of the hot flushes and night sweats as well. But we do think that it might interact a little bit with the neurotransmission and circadian rhythms as well. And then, of course, the impact on mood. We do know that there is some interaction with some of the neuropsychiatric illnesses as well. So estrogen does have a large role. I don't think we understand it all fully yet, but we understand enough that does have a very strong protective factor over a lot of the parts of our brain. Um, okay, so what role does replacing our hormones play? So there's a point here that I just want to make that I'm always trying to be very passionate about this as well because we've had a big change in terminology. I don't know if any of you, well, I'm assuming a lot of you are my age, so you remember the good old Kentucky Fried Chicken that had the
mhm,
change to KFC to rebrand. So we're working to change hormone replacement therapy because really that's suggesting that there's something deficient about menopause, there's something wrong, or it's an illness, for example, but really this is a normal phase of our reproductive life. So we've really like to use the terminology menopausal hormone therapy, which means we're providing hormones to treat the symptoms of menopause. We're not replacing, because we're all deficient or there's something wrong with us. So I think the language becomes very important about how we think about ourselves as well. So if we think about it that, so we're just treating the symptoms with hormones, we're not replacing something because we're deficient. Or, in the old days, there was this thought that estrogen's a fountain of youth, and, we had to have it because, we were to stop women from aging. Well, I mean, what's wrong with aging, right? That's part of life. Men don't have to take anything to keep themselves young. So I think the language is important. We do know that there are potentially some positive effects, or at least neutral. So there's no negative effects if we use menopausal hormone therapy in the way that it's meant to be used. We do know for women who have an early menopause, premature menopause, surgical menopause, that they are a group that really, really need their menopausal hormonal therapy up until the age of a natural menopause. It's
Actually, and
not.
that speaks to a question that we just had actually just then too from Natasha about whether, the effects of an earlier menopause mean that you experience a longer duration of cognitive change.
It does put you at higher risk of dementia, having an early. That is the one thing that is very different here. So a premature menopause, so under the age of 40, does put you at higher risk if you're not treated. So it's very important for lots of things, for our bone health, for our cardiovascular health. You would agree with that, Kelly, that that's really the place that we really want to advocate strongly for women. That it's now been a well-established fact that unless there's any medical contraindications, that really should be treated with hormones until natural menopause age, which is 51.
Yeah, so we don't think estrogen's the fountain of youth, but the lack of estrogen too early can be the fountain of oldness.
Yeah, that's right. That's right, and that's where it's a little bit different.
Yeah,
Yeah.
yeah. Mhm.
So, and that has changed. A lot of things around menopause have changed, which is why it's great someone like Kelly's doing something like this, so that we can really get the message out to as many women as possible. We can't treat or prescribe menopause hormonal therapy to treat the brain glitches or cognitive changes, keeping in mind, though, that we've said that this is also multifactorial. So if your hot flushes or night sweats are keeping you awake overnight and that's impacting your cognition more, yes, then that's where we treat. So I'm hoping that makes sense to people. So whilst if someone was sort of swimmingly sailing through, we couldn't say, well, if we give you estrogen and progesterone, this is going to 100% fix these cognitive changes. We just don't have the evidence out there to back that. I mean, that things like this we're going to learn more and more as time goes on, but we don't have that at the moment. Just like we can't to prevent a heart attack, we can't.
Just on that last point, we've had a couple of comments there, Marita. Trudy's asked about the actual age that you classify as being an earlier menopause, or does that count if you've got perimenopause going from late 30s into early 40s? My approach to it's always been that if I've got a woman much younger than 45 who's gone into complete menopause, I will put her on MHT until the usual age of menopause, because that's 5 or 6 years of extra exposure to low estrogen that she's going to have, which are risk factors for premature heart disease and bone loss. So, yeah. And the other question there, someone was saying if it's not indicated for brain glitches and cognitive changes, does that mean that the MHT isn't going to help her remember or function at work? Well, no, that's not the case. What we're talking about when it's not indicated for brain glitches, we're talking about a medical indication. So in terms of therapeutic goods approval, what are medical indications for any of these treatments? The primary indications for estrogen therapy, for example, are debilitating hot flushes or osteoporosis. osteoporosis, or if you've gone through too early a menopause, as we've just discussed. But if you are actually treating your menopausal symptoms, like your hot flushes, for example, with
Mm.
estrogen therapy, you may notice some really good improvements in symptoms around a big variety of different
Mm.
organ systems. It's just that we don't primarily prescribe it just for your brain fog,
That.
or because you're worried about developing heart disease or any of those things. It's just a bit of a
Mhm.
bonus, if you do find that you get improvements in those symptoms. Mm.
Yeah,
Sorry,
yeah.
sorry for that intergestion.
So
Yeah.
so our advice, which we've sort of talked
Mm.
about, is, when you're having the brain glitches or cognitive changes,
Mm.
if you do have the vasomotor symptoms, using MHT or non-hormonal treatments may improve cognitive function because it's lessening the symptoms that are impacting on sleep or ability to concentrate. Or, some women tell me that when they're presenting at work functions, for example, having a hot flush just totally throws them off track and they
Mm.
can't concentrate, and they get confused, anxious, and all that then impacts. So treating that will improve cognitive function. Improving sleep, that we've talked about, using mnemonic devices. So someone's already talked about their lists. I listened to an All in the Minds program years ago now that said, if you do have this distractibility and you're forgetting where you're putting your keys, or forgetting if you've turned things off, or forgetting if you've locked the door, saying it out loud. So keys in handbag, or hot plate off, or wallet in pocket. You won't remember that you've done the action, but you'll remember that you've said it out loud. So using things like that's really helpful.
Mm.
And physical activity, which we're going to talk a bit about later as well, may also lessen those transitional cognitive deficits. Now, a lot of women who come to see me in that menopausal phase, when they haven't really talked about menopause, come because of their cognitive change, and they get very, very stressed and worried that they're developing dementia. It might be that they had a parent with, an older age dementia, so they feel worried that they might be at risk. We don't tend to do cognitive testing in that setting, and that's the same for a whole range of presentations. What we do is try and work with the symptoms, unpick what's going on. So come on to the fact that, okay, so tell me when your last period was. Oh, they've become really erratic, actually. Okay, so
Mhm.
have you noticed this? Have you noticed that? And all of a sudden, we're at this point where, okay, well, it sounds like you're, transitioning into menopause. That's probably what's causing these issues. Let's look and see if we can optimize what's going on here, and then we come back and revisit those cognitive changes. And I want to kind of send the message to everyone here, because we do find that people with an younger onset of dementia do really struggle to get the diagnosis. So if you had that at menopause and we treated your symptoms, and perhaps there was some depression and we treated that, if all of that had been treated and we'd optimized it as best we could, and you were still having cognitive changes, then you come back to your doctor and say, I'm still worried. I'm still experiencing these changes. And that's when we might go, okay, well, let's look a little bit closer at this.
Mm.
Okay, so remember,
Mhm.
and if you find that you've got a GP who hasn't been able to listen or hasn't heard, perhaps that's always, for whatever reason, everyone has their own sort of biases. You go, I think I might just go and talk to someone else and just run it by someone else. You can
Yeah.
do that whenever you feel like perhaps.
It's so empowering. I mean, that's what's so special about, this kind of thing, is just getting this information at the right time. It gives you
Yeah,
that feeling of empowerment that you can go and advocate for yourself and ask more questions, or even go and talk to somebody different if you're not getting the answers you need.
yeah.
Yeah.
Or bring someone with you to the consult,
Mm.
someone who can help you navigate that conversation.
Mm.
So remember, us poor doctors, we are only human. We are not
Mm.
perfect. We try
Mhm.
our best, but we're not perfect. Um, so that's for that. So now we're gonna move on to dementia. Now, why do we wanna talk about dementia? Because it is increasing. We're an aging population, and so we are going to be seeing more and more dementia. In fact, every 3 seconds around the world, someone is developing a dementia. If we look at the cost, and this is in US dollars here, but the cost is the cost to the health system, the cost to people living with dementia, the cost to their carers is enormous.
Mm.
And although there's no cure, or no curative treatment, there is a lot that we can do to ensure that people with dementia live well, and that's what we'll be talking about a bit tonight. And so if we start with how would we define dementia, and this is really important. So I probably started in the education space around dementia. A lot of it was prompted by having a father who had dementia, and having an association with Wicking in Tassie, who do the MOOCs. So at that point in time, I really didn't understand what dementia was. I remember people saying back then it was a terminal condition. I was like, no, you die with dementia, you don't die from dementia. But I have since learned, with the correct definition of what dementia is, it's a progressive, global, life-limiting condition. It's a terminal condition that involves generalized brain degeneration. And just like menopause, it affects people in different ways and has very many different forms. No two people with dementia present the same way for similar reasons. A lot depends on what else is going on in their life, what other illnesses they have, who's at home with them, what sort of financial security they have. All those things can impact on how someone may present. So dementia also, it's a collection of symptoms, or it's a syndrome. It's not one illness. There are hundreds of causes of dementia. The most common in developed countries is Alzheimer's disease by far. About 60% of cases of dementia will be diagnosed as an Alzheimer's disease. Then you get a vascular dementia. So the same as we have risk factors for heart attacks or strokes, those risk factors are similar for a vascular dementia. And often, because of the nature of these illnesses, we see Alzheimer's and vascular can present together. There can be a mixed pattern, a bit of both going on. And then probably the next common would be a Lewy body dementia. So I'm sure most people will have heard of Parkinson's disease. It's the same pathology of Parkinson's disease, but in a different part of the brain, in the cortex of our brain. And then we have frontotemporal dementias, which again is more commonly seen probably in the younger onset. But in Africa, for example, the most common cause of dementia is HIV or AIDS. So, we wouldn't think about that necessarily here in Australia because we don't see as much, but that's, different countries have different main causes. But there are lots of different reasons and lots of different causes, and some can be a lot harder to pick out than others. So what are the early signs of dementia? Memory loss, and I'm sure we've all had that experience of knowing someone who repeats the same story over again, or has trouble remembering things. Difficulty performing some familiar tasks, so that can be using the microwave, following a recipe, using the lawnmower. Language problems, so word finding difficulty, or difficulty perhaps following stories, or difficulty expressing their needs or their wants. And there can be some significant changes in personality. But I don't know about you, Kelly, but when I say all that, it sounds very similar to what I said earlier as well about some of those cognitive changes that happen in that transitional phase. So, we talked already about forgetting our appointments, forgetting where we'd put our wallet, not remembering why we'd gone into the pantry. But the difference with dementia is, I guess, that it's more than memory. It affects, as we said before, it sort of affects us more globally. So we talk about there being 5 domains that dementia impacts on for someone living with dementia. The first domain being cognition. So that's sort of thinking and memory, and language. So that's, how we describe cognition. But there also has to be an impact on our function. So, it has to be more than forgetting things, and it has to be more than perhaps leaving the chicken on the stove like I did last night and rescuing it just before it burnt. It really has to impact on our ability. Like I'm making those changes, but I'm still going to work every day and functioning very well as a doctor most of the time. So it has to impact on our ability to function. And we often see that both of those things that have been happening and deteriorating over time. So we often say to people when we're exploring whether there's a diagnosis of dementia, tell me how mum or dad was 1 year ago or 3 years ago. And they'll say, oh gosh, 3 years ago, mum was still making the Christmas puddings. The grandkids were all still getting their birthday cards with their $5 note in it. But she's not doing that anymore. And so you see this real change in function. And then there can be psychiatric issues. And again, depression, anxiety can be part of an emerging dementia, but they can happen any time through the course of an illness. And more significantly, we can see delusions or I've forgotten the other word now. Delusions and
Or
hallucinations. So seeing things that aren't there or thinking things. There's often in that very early phase when people are misplacing things, they get delusions, paranoid delusions that someone's coming into the house and moving their things or stealing their things. Or if their partner's going out, there can often be delusions about partners having affairs. That's a very common one that we see. So those psychiatric issues can kind of wax and wane throughout the course of a dementia. And then there's behavioural changes. Now, they might be early on where people start to become apathetic or low motivation, or they're not wanting to go out as much. And often in those early stages, it's because people with dementia can have difficulty making sense of their surroundings or their context. So whilst they might manage very well at home in the safety of their own home and their own routines, if they go out perhaps to the bowls or to play bridge or whatever their social things are, things become a lot harder. So they start to withdraw and stay at home. Or as the illness progresses, some of the behaviours can become a little bit more challenging. And then, of course, there's a physical decline, which really starts to manifest later in the course of the illness, where people might start to have falls, or they might start to have difficulties swallowing. They become incontinent of urine and feces towards the end and really become bedbound. And that's really at those very end stages. So it's more than memory, which is what the take-home message is.
Yeah, those 5 domains very much fit with that that definition you put up earlier of it being a global kind of process, isn't it? It's
Yeah.
across a whole bunch of areas.
Yeah,
Mm,
so I guess that what I'm trying to really explain is it's quite different to just having the brain fog,
mm,
and some of those cognitive changes. There's not those other things that tend to go, with the more progressive phase of the illness.
mm,
So, why do we come back to discussing women and dementia? And I guess important to sort of note here that there are differences with a lot of illnesses and our sex and also I guess our gender. So we see that as women we have much stronger immune systems compared to men. So men are much more likely to die from infections than women because we have a stronger immune system. But because we have a stronger immune system, we're also more at risk of autoimmune disease. So things like lupus or arthritis, where unfortunately tend to have more of those illnesses. So our sex does play a role in medicine, and in dementia particularly it becomes very important because 2/3 of all people living with dementia are women. So
mm,
that's really important. And I'm just going to go through a few sort of important slides here as well. So this one is looking at the prevalence rate. So these are the latest statistics out of the Australian Institute of Health and Welfare. So we can see that dementia's increasing, which we've already talked about. So the top line there, if I pop this up, this is everyone. Then if we look at this line up here, this is women, and then the bottom line is men. So already far more women than men have dementia, but you can see that that gap's getting bigger. Partly that's related to women living longer, but
mm,
that's not all of the story. So we'll talk a little bit about that in a minute too. So this one is really interesting. I want everyone who's listening even to have a look at that. Now, this is the cause of death for women in Australia. So the leading cause of death for women is dementia, and not many people know that. This is something that's becoming, much more understood, but probably that's only been in the last couple of years. So dementia is the leading cause. And I'm just wondering if women have a think about what they would have thought would be the most common cause of death in women. I'm just wondering if anyone would be keen to pop a message in the chat box of what they would have thought was the most likely cause of death for women, or the thing that worries them the most that might cause them. Yeah, so
Mm,
Susan, that's music to my ears, because so many women are worried about breast cancer, and
mm,
you can see their breast cancer's not even in the top 5 there.
mm.
So, we do have lung cancer there, but it's interesting, isn't it?
Mhm,
So,
mhm.
a good
Definitely,
thing.
and when we're having our discussions about women's health, breast cancer risk looms large the moment that you mention
Yeah,
hormonal therapy anytime. But actually, when we say, well, hang on a minute, how about the fact that having low estrogen really causes your heart disease risk to rise? And that's actually a much bigger chance of, you dying from
yeah,
that than breast cancer. So yeah,
yeah,
it's really weird how our perception gets skewed by our fears,
yeah.
isn't it?
Yeah, and I mean, I think part of that is that, breast cancer's
Mm,
had a lot of airplay, which is fantastic, and we have, great organisations like the McGrath Foundation that has really worked hard to support
mm,
women with breast cancer, but no one really cares much about dementia,
mm,
and I care about it because it affects women in many ways, and, which we'll talk about also, but
mm,
it's us postmenopausal women,
mhm,
and,
mhm,
someone's gotta care about us, and so I'm gonna care about us.
mhm,
And so this is the next really important slide. So it also has the biggest impact on our quality of life. It's the biggest burden of disease for women. So we can see breast cancer actually makes it in there, but dementia is what is causing the biggest impact on elderly women. So why are we talking women and dementia? More women live with dementia than men. Women's symptoms tend to be more severe, and they tend to progress a lot quicker. They tend to be diagnosed later than men. And now, this is a really interesting fact because they feel that women maintain their verbal memory much better than men. And a
mm,
lot of the screening tests, got to keep in mind, there are no diagnostic tests for dementia, which is what makes it hard for us as doctors to diagnose because there's no blood test we can do at this point in time. There's no scan we can do and say, here we go, you've got dementia because it's here in the blood test and it's here on the scan. So we do screening tests, and a lot of our screening tests are based on verbal memory. And so
mm,
women do much better on these tests, and so perhaps they're picked up later, further on in the disease course, than what men are. And there's also probably a thought here that men tend to often have someone looking after them. So men retire in life, and then this is the very traditional, very sort of patriarchal representation. I know there's all different, kinds of ways that we all live, but this is just, the image I want to kind of create today. So a man retires from his job. He's not been someone who's been functional around the house or a primary carer or tending to all the grandchildren's birthdays, Christmases, the Christmas festivities. I mean, I've been married, I think 35, 36 years. I still do all the Christmas shopping. But that's what
mhm,
how a lot of family structures end up. So there is some thought that perhaps the women look after men, almost protect them in that stage. So it may be that no one is aware that they're getting dementia either because someone's doing everything for them. But when women who have been a central role have a much more visible role in those later years, perhaps that's one of the reasons as well. There's
mhm,
still lots and lots and lots we have to work out here. And the other big point, most of the care of people living with dementia is done by women, and that's either in paid or unpaid roles. So not only does dementia affect women directly, it's the indirect effects here that are also really important and often contribute to our menopause because we're often looking after elderly parents. Oh, excuse me.
mm.
Okay, so here's where we get to some of the really important stuff, and some of the stuff I
And
really.
sorry, this is a good time to point out that a lot of women I'm noticing in the chat box about now are writing comments like how frightening this is to hear and how awful it's been to watch parents going through it. And
Yeah,
I have to you just interject there and say that the purpose of this talk isn't meant to scare the pants off you so much as it is to reshift focus to to what are the bigger areas of risk for older
yeah,
women and how we can go about actually protecting ourselves from those. So this is the good part of the talk you want to
yeah,
listen to
yeah. And the
about
good
how we can actually prevent that, or at least reduce our risk. So
Yeah, and we
yeah.
can, and there are things we can do, which is great. So this
Mm,
is a little flow chart, which has got, the I guess the key thing is there's 60% of risk that we really are unsure of at this point in time, that we don't really know, that we can't change. There's some sort of evidence around some genetic components some genes that can be protective or put us at more risk, and we're really still working through these. If we go up to this little green circle, one of the things that we really can't change also at this stage for us is our early life education. So possibly the women we're seeing in their 80s, 90s, 70s, 80s, 90s didn't have the same opportunity as a lot of us to go to school, go to university, do courses, come back to uni later in life, for example. So some of the women perhaps we're seeing in that stage might not have gotten through very far through school at all. I mean, I remember my mum actually, she finished school, she became a nurse. She wasn't allowed to work once she was married as a nurse in that day. So a
mm.
lot of women sort of cut out of ongoing education as well. So there's not much we can change about that for us or for older generations, but we can put a very strong focus on making sure that all our younger children do get access to good education. And I don't know how we change that, putting better money into schools, but that is something we all need to pay attention to. Those first 1,000 days for kids are very, very important. There is some evidence that, and this is where we'll get back to the crosswords, that going to uni later in life can be a little bit protective. And in fact, in Tasmania, they have a project there called the Healthy Brain Project, where people have been able to enroll into university courses, and they've studied them with memory testing and MRIs, and there is some emerging evidence that actually that can be quite protective. Now, if you do crosswords all the time, is that going to prevent dementia? No, it's going to make you really good at crosswords. What's really going to help is if you do a crossword, you mix it up with a Sudoku, perhaps you learn a language, you learn an instrument, you're doing different things to access different parts of your brain to improve the connectivity of your brain. So doing one thing will make you good at that thing. It may not necessarily help prevent dementia. So I think yeah, I'm sorry that you can't see this close up, but I will talk through it. So this is this early bit of education, which they think might contribute to a 7% population sort of risk factor. So remember, these are population-based. We can't work this out exactly for individual people. Now, if we go on to this is sort of midlife area. So we've got early life, then midlife. And so hearing loss, I mean, who would have thought that hearing loss would be a problem? And this has been a really interesting one, because when I see people now who are in middle age and they come back because they've had problems hearing, or they've had, you know, some pathology in the ear, and they've been left with some hearing impairment, and they say, "Oh, it doesn't really bother me that much." And when you say, "Well, did you know actually it could be a little bit of something that could help protect you against dementia, either prevent you from getting it or delay the onset? Do you think you might want to do something about your hearing now?" And people go, "Oh, well, in that case, yeah, I will." So hearing loss, we're not sure if that's a marker for brain change, or if that's people become a bit more socially isolated. Traumatic brain injury. So we've heard a lot about footballers in recent times and concussions from sport, and how important it is that we protect our kids from sporting injuries, that they have the right amount of time off. They can't keep going back on the field getting concussed. And certainly they're looking into that into people like the professional footballers. Hypertension, high blood pressure, very important for us women. This has been there was a big study done by an Australian woman, Karen Anstey was the chief investigator, and she did identify that midlife blood pressure is important. And traditionally, of course, what do? We focus on men with blood pressure to prevent their heart attacks. We work really hard to stop them smoking, but we tend not to be as aggressive with women. And maybe we have to. Maybe that's something we can change as doctors to say, okay, we're going to really pay attention to your blood pressure and look at what we can do. That's why when we see you for a menopause consult, we always like to know what your blood pressure is. It's always a really important piece of information. So that's something that we can definitely do stuff about. Alcohol, they've got here, as long as you don't drink more than 21 standard drinks per week. Now, that's evidence. This is evidence-based. We do know that really in the real world, there is no safe level of alcohol consumption. But at this point in time, that's what we're saying. And obesity. So being obese puts us at high risk of a lot of things. And again, obesity is multifactorial. It's not just because you eat too much or you're lazy. There are lots of factors that go into that as well. But we can always work to address those. And we know if we can reduce our body weight by 5%, our health benefits are amazing. That's only 5%. Not easy. So then later in life, which is down in this purple bit, the other things that we need to think about, of course, is smoking, and we've really got to try and stop smoking. Depression. Women are more prone to depression. We are a little bit more prone to depression post-menopause as well, just like puberty blues, postnatal depression. At those transitional points, we're a little bit more prone. So we want to treat people who are in that phase for depression so that we can not only make you feel better, but also look at preventing the dementia or delaying the onset. Social isolation, again, very important. And that's important for everyone. Physical inactivity, that's another real big one for women. We're going to talk a little bit about that later. Air pollution, well, that's not in our control a lot of the time. That's more government that have to look at that as well. And diabetes, and of course, diabetes has it's a risk for heart disease, kidney disease, and dementia. So that's because of the what it does to our vascular system, our cardiovascular system.
Someone asked a question too, Marita. Linley's asked, is improved nutrition a modifiable factor? So is poor nutrition a factor, and can we, improve our nutrition to have a preventive health benefit against dementia?
Look, there is more and more coming out about that, and I guess poor nutrition can lead to high blood pressure. It can lead to obesity. There is some thought, particularly now, the gut-mind connect, so that poor nutrition can also lead to mood change. So definitely nutrition. The jury's out as to what the best way of doing that is. But I was speaking to someone the other day, one of the neuroscientists, who said we talk about the Mediterranean diet. We know that that's good. There's also the DASH diet. But essentially, I think one of the things they are isolating is lots of greens, spinach, kale, lettuce. They're things that are becoming more. It's becoming clearer that eating lots of those are good for us. But at this point in time, there's no clear 100% evidence that we say if you eat this diet, you'll prevent dementia. But good nutrition, remember, is important for loads of different things.
Oh yeah, it's across the board beneficial in cancer prevention and just general health and vitality and so many other things.
Good on you, Michelle, for putting that link there. That's fantastic. So you can have a closer look at the Lancet. Other risk factors that aren't really necessarily in the Lancet Commission, but are things that have been earmarked, are previous trauma, things like domestic violence, which do impact more on women than men. Now, the caring role is an important one, because we don't want to say stop caring, because being a caring person is a very good thing to do. I think it's really about recognizing that we do take on a lot of caring roles, and so we have to remember about trying to care for ourselves in that. And we talk a lot about we pay a lot of lip service to self-care. Oh, you've got to look after yourself so you can look after others. We really want to say you want to look after yourself just to look after yourself,
Mm.
just to feel better and happier yourself as well. So stress in midlife, which we kind of have alluded to several times before, and there is a lot of stress in midlife. It doesn't mean if you're having a stressful midlife, you're definitely going to get dementia, but it's about saying, okay, I'm going to do what I can to try best to manage the stress I can. Depression, we've talked about as being a risk factor, and also the women who have had a surgical menopause. And interestingly, sometimes there's been more coming out about women who have preeclampsia in pregnancy,
Mm.
that
Mm.
fact as well. So the surgical or the early menopause, we know that we can do things about that, and I'm sure there's research happening in the space of preeclampsia as well. I mean, treatment for that's getting a lot better as well. In fact, my poor old dad who died from dementia, he actually did his PhD in studying the incidence of preeclampsia in twin pregnancies. We had
Oh,
loads of urine bottles everywhere in our house and our cars because he was always collecting people's urine. Um, so a little
you
side
better
thing
be
there.
careful reaching for the Gatorade in your fridge.
I know, right? Um, so now we come to I'm not even sure what the time is. I've got no idea. How are we going for
So
time?
we're just on 9 o'clock now, Marita.
Okay, great. We're doing not too bad. So these are the take-home messages. So, and I hope I've sent this message through the talk. And this is really what's coming out of some fantastic research that's being done by women for women. Is it's really important that as women in our 50s, 60s, 40s, 50s, 60s, in this sort of transitional menopausal phase, that we have to prioritize our health. And one of the most important things we can do is actually find something, which is the bottom point, we enjoy doing that's physical and get moving. And that's good for our bones, it's good for our hearts, it's good for our joints, it's good for our weight, it's good for our mood, and it will help prevent dementia. There is no cure for dementia at this point in time. There's plenty of research going on, but keep in mind, part of the issue again is that there's probably not as many women involved in the trials and the research as there should be, not representative of the 2/3 of women, 2/3 of the population who have dementia. They're sort of 50-50. We've really got to get more research in the trials, drug trials, with women in them. So there is no cure at this point in time, but we can work to prevent getting dementia or just delaying the onset. And I don't know about you guys, but if I got it at 90 instead of 80 or 80 instead of 70, I think I'd be a happier person, or feel that you got more quality of life. That's not to say that people living with dementia can't have quality of life. They can. And the earlier that we can diagnose and support people through that journey and their carers, the better quality of life they have. So we're going to prioritize our own health. We're going to go home tonight and we're going to say, well, we probably are home, but we're going to get off the webinar tonight and we're going to say, right, what change can I make? I have to find some kind of physical activity. That can just be walking, whatever you enjoy, but you do it every day. And I'm going to start looking at what changes I need to do to put me first. And Kate Gregorovich, who's a geriatrician, who's written a book called, well, we've got a reference for this later, Staying Alive Longer, something like that. We'll show you in a minute.
Mm.
She gives this lovely story about oxygen when you're on the plane, and the pilot says, in the event of an emergency, get your oxygen first so that you can then help your kid. You put on first. She says, why can't they just say get the oxygen because you need it and you deserve it, not because you've got to look after someone else? And I think that's a really key message, that as women in this phase, we've got a lot going on. We have to start prioritizing our own health. Sometimes that might be just making an appointment to start talking about what's going on for you at menopause and how perhaps your GP can help you through that period to set you up for a longer and healthier life. So that's my take-home message and my challenge for you all to do something to prioritize your life. So just going quickly through the references, because I know you want to ask some questions. This is the Preventing Dementia MOOC and the Understanding Dementia MOOC, both terrific online courses. They're free. They're very easy to do online, and you'll learn loads. I've done them all a few times because I sort of update them and add little bits of info. They're terrific. I'm trying to get everyone I know who's a doctor. Now, Dementia in Practice, this is a podcast that I've been doing with two of my colleagues. It is really targeted towards GPs, healthcare professionals, but we have had so many people who have just listened to it out of interest, who have given us feedback to say they've really enjoyed and learnt little bits of information out of that as well. We've talked to lots of different experts about it. This is a fantastic podcast I've just found and I've been listening to called Talking Dementia with Heckle and Jekyll. These are two women in their 50s, healthcare professionals diagnosed with dementia, and their humour and their rawness is just so wonderful. And I feel like I have learned so much by listening to their podcasts. And sometimes I'm in the car just laughing my head off at some of their stories that they share. And other times I find myself crying because, it is so raw.
And I can't wait to listen to that. And just for you ladies that are asking about whether the slides and things will be available, I'm not sending around the slides, but the resources that Marita is recommending here will be emailed out to you very shortly.
Yeah, so these two books are on my list for Christmas. I haven't read them yet, but I'm going to. That's what I'm going to do to prioritize a change for me, because I really want to read these. Secrets of Women's Healthy Aging. So Cassandra Circa, she's led a 30-year study now into, I think, 400 women, looking at what things can help to help us age better. And for us, again, it's not about staying youthful for other people or looking fabulous. It's about what we can do so that we can enjoy our later years. And this is Kate Gregorovich's book, Staying Alive, The Science of Living Healthier, Happier and Longer. And this is a project that Kate also has set up called Project 3612. And this is, again, with that recognition that to prevent dementia or to delay the onset, now is when we've got to start acting, because this is the disease process starts 20 to 30 years before symptoms. This is, specifically with Alzheimer's. So now is the time to act. And this is a project that engages women who haven't been physically active for some time, which, let's face it, for lots of us, it is a real challenge to do that. This is a way of getting back into it. Different forms of exercise. There's nutritional webinars. There's all sorts of information through the project, and it's all online, developed by her and an exercise physiologist. So if any of you are looking for something to do, you can jump online and have a look and see if that might be something that might work for you in terms of getting back into some physical activity. So I hope you found that information useful. As Kelly said, it's not to scare people, but I think as women we do need to know the facts, and we do need to know that dementia is the leading cause of death, and that there are more of us living with dementia than men, but more importantly what we can do about it. And part of that is really addressing our health at this menopausal and transitional phase.
That was gorgeous. Thank you so much. That was so informative. You had so much in there. And as I mentioned, we'll send around the resources that Marita had linked there at the end. So for me, putting that all in a nutshell, Marita, to start with, we saw how very, very common brain fog and memory loss and everything is. It's pretty much in the realm of normal in the menopausal transition to be experiencing these things, especially when you've got more than 50% of us at any given time experiencing it. So, everyone's seen now what the difference is, between just the common isolated symptoms that you'll have from time to time with that versus the more global process of dementia, which is pervasive, progressive, and then really affecting your functioning in a lot of ways. And we've also heard really important things about risk factors that are modifiable, but also really, really the importance of movement, as one of the really easily easy things that we can do that's been strongly proven to be protective against dementia and lots of other forms of cancer and heart disease and everything. So the message is really loud and clear. We have to get moving, girls. Absolutely. And, as I say to my patients, I don't want to hear that you haven't got time to go out of the house and do a big exercise class. I want to know why you haven't got, time in your day to do 5 minutes of just jogging on the spot, or,
Yeah.
sprints on the exercise bike, or skipping rope, or even just going up and down the stairs. So if you can find little snippets of snacker-size time to do that more vigorous exercise, it's going to be incredibly powerful if you're doing it regularly. So, stop thinking about it, stop making excuses, just, like, go up your nearest set of
Yeah.
stairs and just do it.
Yeah. And if
Mm,
you wanna talk about, those things, just remember, you've got your own GPs, but you also have us here at WellFemme that can all be done, online through telehealth.
absolutely, absolutely. So without further ado, let's get into a few more of the questions that we haven't gotten to yet. So it's nearly 9:10, so let's do about 10 minutes or so of questions. Is that all right with you,
Yeah.
Marita?
Yeah,
Yeah, so
sure.
there's a few things in that. Now, I think you already addressed what Ruby asked earlier about the crosswords being good for the brain, and by themselves good for getting good at crosswords, but you need to kind of get a variety of things in there.
Yeah,
Okay, we'd heard a bit about the effects of the earlier menopause there.
yeah,
Are there tests to distinguish so we're talking about the testing type thing there. Deborah was asking about tests to
mm,
distinguish dementia compared to the various other more common causes of menopausal brain. And I was wondering
mm,
about that myself, because
mm,
often when people come to me and they're
mm,
concerned that, there's
mm,
something wrong with my memory, I'll do a mini
mm,
mental state examination
mm,
on them.
mm.
Is there a role for that? Is there a role for other, commonly done
Um,
sort of testing?
the the thoughts really are, if someone is going through the menopause transitional phase, that you treat that. That's where you start. So you look at what the symptoms are. So, are they having hot flushes? Are they having poor sleep? Are they having joint pain? Are they, feeling fatigued as well? So we look for that. And then it might be that we would think about things also, other things that could impact on brain fog. If we thought it was more than, the average person we saw, we might think of, are they having heavy periods in this transitional phase? Are they iron deficient? Could their
Mm,
thyroid be impacting on their cognition? So we might do some of those tests just to see, is there anything else? Vitamin B12 deficiency. Sometimes I see women who in that menopause phase do a real turnabout lifestyle change and become vegan. And you're like, okay, so, they haven't probably really explored how to make sure they're getting all their nutritional requirements. So are they B12 deficient? And then we
mm,
would treat those, and then we would come back and revisit it. So the mini mental, you can have a perfect mini mental score and still have dementia.
mm,
So
mm,
you can have a really poor mini mental score and not have dementia. There's screening tests, and they have a role, but they're not diagnostic.
more
So
for monitoring, really, I think.
yeah,
Yeah.
and really it's that thing of, if someone is really, concerned, we always think about how do we make a diagnosis, and that's really looking at, do they have memory loss?
Mm,
Is it a gradual onset, and is it getting worse?
mm,
Is there other signs of other brain dysfunction, language problems, um, difficulty doing things that they would ordinarily be able to do, difficulty remembering the names of items? That's an
mm,
important one.
mm, mm,
And is there any sign of any sort of past stroke or vascular disease that might be contributing? And then we look for all the possible other causes, like we talked about before, B12. So there's
mm,
no huge role, um, uh, but it should be a flag for all doctors to say, there's a concern here. We need to treat whatever we can treat, and then we need to make sure we come back in 3 to 6 months and have another talk and another think. So I
mm,
like to think of it like an impaired fasting blood sugar. We don't
mm,
forget about someone who's got a high blood sugar. We put that in our notes to remember to keep monitoring. So I've my friend in Hobart actually coined the term CFM, cognition for monitoring.
mm,
So I would
mm,
always come back and revisit, because it is something that over time, we might pick up. They are
Absolutely.
working on some tests. There are some blood tests that are in the
Mm.
pipeline, but I think they'll be a long way off.
Yeah, there might also be, I know in Canberra, for example, we've got a memory assessment unit, a specialised memory
Yeah,
assessment unit that
yeah,
you can get referred to
yeah.
if somebody's GP really
Becomes
has
really
serious
worried.
concern. So
Yeah,
it's a multidisciplinary clinic at the hospital
yeah,
where they really have that specialised testing ability.
yeah.
Okay, other questions. Somebody asked whether testosterone had a role in the brain the same way that estrogen does.
Not as far as I'm aware.
Mm,
I mean, testosterone is still one of those ones that, again, we're looking into more and more.
mm,
I think with any of these things, we always look to optimize estrogen first,
mm, mm.
and have the progesterone to protect the uterus if you've got a uterus, and then yeah, not in any of the literature that I've read. But remember, I'm not a world expert.
Yeah,
I'm a GP
and it's
specialist.
difficult to say, isn't
Yeah,
it? Because I know that
yeah,
some people who are on testosterone say they get improvement in their
yeah,
cognition. So,
yeah,
but
yeah,
I don't know the mechanism for that. Now,
yeah.
Elizabeth's asked here if MHT was not recommended due to family breast cancer risks, should a second opinion be sought? Yes, by all means, Elizabeth. Sometimes,
Mm,
just like if you get told you can't have MHT just because your mum had breast cancer, then I do think you probably need to speak to somebody else about that. But if it was you who'd had
mm,
breast cancer, the answer would probably still be no, you can't have MHT. But
mm,
yeah, I think that's impossible to say without sort of going in a bit deeper into your medical history there.
mm.
Sonia's asked, my mum had a full hysterectomy in her 40s and then developed dementia in her 50s. I'm now 50 and had a partial hysterectomy 5 years ago. Is my risk factor much higher?
That's a really good question, Sonia. There is a very, small genetic risk. But, again, this is still in very early phases, and, I think it's hard for me to say not knowing exactly what your mum had, what type it was,
Mm,
that's kind of the trajectory. Um, I think if you're worried, though, my suggestion would be that you go and talk to your GP and get them to
yeah.
take a really detailed history, find out as much about your mum's dementia as you can, and then go and talk to your GP.
I mean, from an estrogen perspective, if it's a partial hysterectomy, still leaving the ovaries, then your ovaries should still be able to continue to function at least probably almost up until they otherwise would have naturally anyway.
Mm,
Sometimes there is a slightly earlier menopause when you've had pelvic surgeries, but
mm,
on the whole, as long as your ovaries are still functioning, you're still getting a good
mm.
estrogen supply, generally speaking.
Mm.
What
So
else have we got?
Catherine's asked something about the beta amylase. You're close.
Mm,
It's beta amyloid, and
mm,
there's three things that they're looking at checking, which is the amyloid, and it's which is low. It's also the tau protein, and then also I think it's neurofilament. So it's an
mm,
ATN. There'll be three things, and they'll put all those together. But that's still very much in the research space. It's not going to be
mm.
something that'll be available. I mean, some people say maybe 2-3 years, but the experts in the area seem to think
It'll
it's a
happen
long.
soon.
Yeah.
Jean has asked in regards to neural pruning, if you take MHT, does delaying the pruning phase cause problems with the regrowing phase? Not quite
Does
sure how to.
No, I think with the pruning, I think the pruning is something that's happening irrespective. So the pruning is happening and it's gonna grow back. MHT, remember, is treating those vasomotor symptoms, so the hot
Mm,
flushes. It's treating the urogenital changes and the sleep plus minus some low mood. So
mm,
it's not necessarily impacting on what's that pruning, because that's happening anyway. And not everyone has to have MHT, but everyone will go through that process. I'm
mm,
hoping that answered the
yeah.
question. Mm.
Casey's asked, is there any link between chronic hormonal migraines and dementia? So chronic migraines, chronic hormonal migraines, do you know
Mm.
if there's any link there?
I don't, but there is a fabulous, site called, I think it's the Brain Project, might be the Women's Brain Project. It's a UK initiative, and they're looking into all sorts of, neurological conditions, of which migraine is a big interest. And so you might be able to look that up and just see if they've got anything there. There's nothing that's been um, come to my attention, but again, keeping in mind that a lot of this is still, in its infancy, really, of putting all these things together. So I wouldn't say never, because I'm not 100% sure, but that's a great site to have a look at what sort of research is being done around the world in
Mm.
terms of looking at women's conditions specific to women. Yeah.
Mhm. Okay. Now I'm just going back a bit earlier to see if I've missed any earlier on in the evening. I've tried to write a few down here, but if anyone has any last-minute questions, feel free to pop them in the box now. On the B12 thing, interestingly, you brought that up earlier about B12
Mm.
deficiency. Sometimes people are being treated by integrative doctors with really high doses of B12. Are you aware of any research on the value of that?
No, I mean, my understanding is that you just pee out any excess B12 anyway.
Yes, I my approach has always been to test, like, B12 by all
Mhm.
means, and if it's low,
Mhm.
supplement, but,
Yeah,
a
yeah.
lot of
I
patients
found
have
that at high doses. Yeah.
yeah, I've had a lot of patients who've actually been put despite not having low B12, they've been given it, so,
Mhm. Mm. Yeah, I
so
have had patients in the past who have had, like, chronic fatigue with normal B12,
mm,
who have been started on B12 somewhere and do say they see a real benefit. It's not gonna cause harm, and if
mm,
they feel like it's causing benefit, but yeah, it's kind of that stuff that's out there that isn't part of traditional medicine, I guess. Yeah.
so Trudy's asked, "Is there any link between vitamin D levels and dementia risk?"
Not as far as I know, no, but
Okay.
Vi vitamin D is a real interesting space, because so many people are obsessed with testing vitamin D, and,
Mm,
we know that if someone's got low vitamin D, we give you vitamin D, we'll definitely increase your vitamin D level in your blood. Will it make
mm,
any huge difference for you? Not 100% sure there, unless you've
mm,
got
mm,
being treated for osteoporosis, and it's important that you have good levels.
mm.
But again, there is, a link potentially with multiple sclerosis. Um, yeah, there's a lot still that we don't know.
Hmm. Rhonda's asked, "Is low blood pressure a risk factor?"
No.
Okay, good.
Low
That's
blood pressure is more likely to make you just feel like you wanna faint,
easy.
but no, it's high blood pressure.
Right.
Mm.
On the resources side of the house, and you and I have discussed this before, but if anyone's interested in seeing a really interesting TED talk about the impact of estrogen on the brain, go on Google and type in Lisa Mosconi, Mosconi. She's a
Mhm.
researcher in brain medicine, and she's done a lot of work on estrogen's impact on the brain, and it's quite an enlightening talk, I believe.
Yeah.
Um,
Yeah.
okay, can you see any other questions there that
Uh,
we haven't
any
gotten
studies
to?
looking at anti-inflammatory diets? We're not really sure. Diet is not there, other than we think that the green leafy things are gonna become much more of a bigger thing in the future.
Mm,
Um, is there evidence some women retain memory, brain fog post-menopause? Most women improve. Yeah,
mhm, mhm.
most.
And
I
with
never
me
say
too.
all.
Yeah.
Yeah. Never say all or never say never in
Yes, yes,
medicine.
exactly. I'll
Interesting.
scroll back a bit
Osteogenesis.
further. But I think I mean, there's probably some questions that I've missed earlier, but on the whole, I think we've gotten to most of the questions there. And it's 9:20, so I think we'll call it there, Marita. Again, everybody,
Yeah.
please join me in thanking our amazing Dr. Marita Long for all of that fantastic information about dementia risk and brain glitches at menopause. And of course, Marita and all the other amazing WellFemme menopause doctors are available for you to book in and speak to directly. You don't even need a referral, which is amazing. And so, if you're not sure about any of this stuff, if you're not getting the answers you want from your GP, then please do feel free to get in touch and have a chat with one of us. So that's it for this evening. You should